So, good evening, everyone. Am I audible and visible? Just say hi so that I can know. Hello. Okay. So, hello, everyone. Just say hi so that. Okay. Okay, Nitin. Okay, thanks. So, this is a small session, not more than 1 hour. And the purpose here is to discuss very important images which are based on the standard textbook Ganong as well as Guyton, which are important for not only your INICET examination, for your NEET PG examination, but also for your FMGE examination. And as well as nowadays in the MBBS examination also, they are asking MCQ also. For that, concept building class will be there. So let us start without wasting further time. So let us start without further ado. Image number 1. So you can also answer in the comment section. After seeing the image, it will be better if you interact. Okay. So if you are seeing the image, you can answer, what is this image for? What is this shown in this diagram? Yes, everyone. And what is the diagnosis? Of course, the sign here is called. Good evening, Dr. Devashish. Thanks, Dr. Pradeep. Thank you. I'm very happy to see all of you once again. Wonderful, Dr. Wasim Akram. Cushing disease, wonderful. So, Wasim Akram has told the diagnosis is Cushing disease, but what is this called? You are absolutely correct. It can be Cushing disease. You are absolutely correct. But what is this called? What are these called? Something called as mean something where the cortisol is released wonderful. That is why it is called as purple extraneous. It is called as purple extraneous. Wonderful. So most of you are correct. Namaste, namaste, Ayush. And the purpose here is that it is due to increased cortisol. When there is increased cortisol, in the Cushing disease, there is shifting of, there is lipolysis. Someone asks you if there is a lipolysis, why patient is fat? Because due to unknown reason, we don't know. Okay, there is a peripheral mobilization of the fat from periphery to the central, as well as increased cortisol cause thinning of the skin. It causes thinning of the skin. Thinning of the skin so that it becomes visible. So weakness of the connective tissue is decreasing the elasticity. Yes, Ismail, audio not clear? My audio is clear or not? Everyone, namaste. Deepka, Riya, everyone, good evening. Namaste. My audio is clear? Okay. So because of the thinning of skin, it is called as purple stria, and the diagnosis can be, of course, Cushing syndrome or Cushing disease. Okay. Now the second image, what is this? What is this? Like this. If a patient is coming to your OPD like this, what is this called? I hope my audio is clear. Now it is okay. Okay. Yes. What is this diagnosis? Please tell me. Who is going to tell me this one? Wasim Akram, wonderful. You are absolutely Tauzi's sign, you are correct. But what is this called as? Absolutely correct. This is seen in Tauzi's sign. And what is this called as? It is a wrist drop. No, it is carpopedal spasm. Excessive muscle contraction. Carpopedal pedal spasm. It is asked almost every year. If you see the question paper, almost in every examination, they will ask you, what is this? It is called as carpopedal spasm when excitability is very, very high. When excitability is very, very high, and the reason, the most common reason is hypocalcemia, tetany, hypocalcemia. But it is not the only cause in which you can get carpopedal spasm. So who can tell me the other cause of this carpopedal spasm? Answer again is hypomagnesemia, because magnesium is required for release of parathormone, and parathormone is important for release of free calcium. It is the free calcium which is important, not the total calcium. Okay, so it is the free calcium. So hypocalcemia, hypomagnesemia, and also alkalosis. Alkalosis when there is hyperventilation. When there is hyperventilation, it is due to anxiety, or if you are at mountain, when someone is doing hyperventilation, there will be carbon dioxide washout, and it causes alkalosis. In alkalosis, proteins are the buffer. So they will leave all the proton and catch all the calcium. So free calcium become less. So in all the three conditions, in hypocalcemia, in hypomagnesemia, and in alkalosis, everyone, good evening, everyone, namaste. It's very, very good to see you all again. Okay, so hypocalcemia, hypomagnesemia, and alkalosis, it is carpopedal spasm. Anyone can tell me what is the other sign? One more sign is there called the Chostak sign. It is also seen whenever there is hypocalcemia. So when you tap the facial nerve, okay, there is excessive contraction of your facial muscle. It is called the Chostak sign, and it is all showing you simply increased excitability. Increased excitability. So whenever there is less calcium, stability become less, excitability become more. Okay, and it is called as carpopedal spasm. Okay, what is this called as? Anyone? What is this sign is called as? What is very evident in this image? In day-to-day clinical practice, of course, you will not see this, but it is a very, very important sign which is helping you in making a lot of diagnosis. Only with the help of one concept, one single concept, I will tell you, you can make so many diagnoses, and that concept is, okay, let me wait for your answer. Till then, at least let me tell you, POMC is broken down into ACTH and MSH. Okay, this is the hint. Please see my question. Okay, okay. I think it is. I think now it's okay. So POMC is a precursor which is broken down into ACTH and MSH. This is a hint. Now tell me, what is the diagnosis? What is this shown here? Anyone from first year, second year, final prop, intern, post-intern, FMGE, NEET PG preparation? It is helping you in making a diagnosis. Okay, it is your peri-oral hyperpigmentation. Peri-oral hyperpigmentation, and the cause can be increase in ACTH. Recently asked question in INICET. So whenever there is excessive amount of ACTH, it behave like melanocyte stimulatory hormone. It start behaving like melanocyte stimulatory hormone. It causes hyperpigmentation. So either there is Cushing disease, or there is even Addison disease, or even Nelson syndrome. In Cushing disease, in Addison disease, or in Nelson syndrome, when adrenal cortex is removed, ACTH become very, very high. When ACTH become very, very high, it causes hyperpigmentation. So it is perioral hyperpigmentation, and the reason is increased ACTH. Increase ACTH. Okay, now who is going to tell me this? What is very evident in this image? What is very, very evident? These images are very, very important for clinical diagnosis. I will not tell you before you are telling me the answer. Can you appreciate anything? The size of the finger, something is short. After that, we can discuss the diagnosis. But what is shortened? We have short metacarpal. Yes, doctors, tell me. We have short metacarpals. Which one? Fourth and fifth. And if metacarpals are short, we have knuckle, dimple sign. Normally, we have knuckle. We have four knuckles, isn't it? Can you see? There are four knuckles. And when we have short fourth and fifth metacarpal, we have knuckle, dimple sign. And it is very, very characteristic of either you can say pseudo hypoparathyroidism, pseudo hypoparathyroidism. It is also seen in pseudo hypoparathyroidism, and both are manifestation of the same disease called as Albright osteodystrophy syndrome. Albright osteodystrophy syndrome. So if there is a short fourth and fifth metacarpal, yes, very good. You are absolutely correct, Dr. Jaydev. You are correct. So pseudo hypoparathyroidism, pseudo hypoparathyroidism, both are manifestation of Albright osteodystrophy syndrome. And you know, in pseudo hypoparathyroidism, there is resistance to parathormone hormone. So even though parathormone is normal, even though parathormone is absolutely okay, but receptors are not perfect. They are not perfect. On the other hand, in pseudo hypoparathyroidism, all receptors are perfect. Only receptors on the bone are not working properly. So they are pseudo hypoparathyroidism. Thanks, Dr. Sajan. Thanks a lot for your kind words. All your good wishes keep me going. Thank you. Okay. Now you know, Dr. Sajan, tell me, this is your optic disc. This is your fovea. This is macula. You know that. So optic disc is the area from all these things are losing, coming out. So it is called as which spot? Blind spot. It is called as blind spot. And this is the macula. Macula is the area of highest visual acuity. It is the area of highest visual acuity because you have maximum of rod or cones. We have maximum of the cones. Maximum of the cones, isn't it? Now, these are the two images when you do ophthalmoscopy. Okay, you are seeing the optic disc. Now, who will tell me which is normal and which is abnormal, A or B? Which is normal image and which is not normal or abnormal, you can say. And what are the characteristic images you can see and appreciate? And tell me. Who is going to tell me? See, okay. Can you see the pink color of the optic disc? So pink color is normal. Pink color is normal. And also you can see vessels are not distorted. Vessels are perfectly dilated, isn't it? Very good, doctors. Very good, Shivam. Yes, Dr. Bhavya Jain, you are absolutely correct. B is no abnormal because you can see the pallor. This is pink color. If you appreciate, A image is pink color, B image is having some pallor. Very good. And also, vessels are distorted. Who can tell me the diagnosis? Who can tell me the diagnosis? Vessels are distorted. Anyone? Very good. Excellent. Glaucoma. Glaucoma.
So whenever there is increased intraocular pressure, vessels become distorted and this become pallor. I mean, it is not pink in color. And even the cupping of disc is increased. If you can appreciate cupping of the disc, cupping of the disc. So there are three features of glaucoma. One is the pallor, vessels are distorted, and the cupping is increased. Okay. So you can say B images glaucoma, A images normal. Absolutely, most of you are correct. Thank you. Next question. What is shown in this image? Okay, should I enlarge this? Very good. It is central cyanosis. Excellent. Central cyanosis. Very good. Excellent. So you know central cyanosis? It is the bluish discoloration due to reduced hemoglobin. It can be because of respiratory disease, if you cannot take the proper, or because of the cardiac some ailment, or because of the some blood ailment like methemoglobinuria, like that. There can be three manifestation, either respiratory disease or cardiac disease or blood ailments. Okay. Now, there are two type of pathway. One pathway is called as light reflex, other is called as visual reflex. Tell me, doctors, please tell me, which pathway is this and what are the characteristics? I have selected very, very important point which are going to help you not only in physiology, it will help you in understanding of your medicine also. So first point, let me give you a hint. First point, it is started from ganglion cell, not from rod and cone. Yes, very good. Light reflex. It is light reflex. And doctors, you know, light reflex are of two type, direct and consensual or indirect, you can say. So when some patient come to your ICU or some, after road traffic accident, you put the torch. So what you want to see in the torch, by the torch? So that if people constrict, meaning by whole pathway is intact. So when someone put torch, you cannot see. It is not the visual pathway. It is the light reflex. It does not start from the photoreceptor. It starts from the ganglion cell. Which pigment? Who can tell me? Which pigment is there? Rhodopsin, photopsin? No. Neither rhodopsin nor photopsin. It is melanopsin. Latest MCQ. Melanopsin. Melanopsin is very, very sensitive to the light. It is not the photopsin. Rod and cones are not involved, my dear doctors. It is the ganglion cell having melanopsin, and it bypass lateral geniculate body, goes to pretectal nucleus, doctors. When you put light, torch, okay, and Edinger-Westphal nucleus is involved, causing pupillary constrictor muscle. So people will constrict through the ciliary ganglion. So it is bypassing your lateral geniculate body, cranial nerve or third is involved, and this is your light reflex. It is not the visual reflex. A lot of differences are there in the light reflex and the visual reflex, doctors. So this is light reflex. So just by putting a torch, you can know whole tract is intact. Okay. And the second pathway is your vision by which you are seeing me. So this will start from your rod and cones. Of course, it will be taken by ganglion cell. But the receptors are where? Where are the receptor, doctor? Answer is rod and cone, rhodopsin and photopsin. You know, this is your temporal field. This is your nasal field. It will crisscross like this. Temporal field will go to nasal hemiretina. Nasal field will go to temporal hemiretina. Now tell me, which will cross in optic chiasma? Is it temporal field will cross or nasal field will cross? Always remember, if you remember only this point, you can solve whole pathway. Any MCQ regarding whole pathway, just remember one point. And what is that point? Thanks a lot, cricket expert. Thank you. Okay, thanks a lot. So if light is coming from this side, it is temporal, and this is your nasal hemiretina. Now, after that, which is going to cross? It is your optic chiasma. It is your optic chiasma, doctors. Okay, optic chiasma, and then it will go to lateral geniculate body, and then it goes to occipital cortex. It goes to your occipital cortex. See, thalamus is like an antenna, and your cortex is like a television. You can see in the television only because of the antenna. So everything has to relay in the thalamus. Whatever, pain, touch, temperature, light, whatever, everything have to relay in the thalamus. And here it is lateral geniculate body. Here it is lateral geniculate body. And then the television is occipital cortex. Now doctors tell me, if lesion is at the point A. Thank you, Srijan. Thank you. Lesion is at point A. If lesion is at point A, whole side of the left will be gone. If lesion is at point A, whole side of the vision will be gone. And if lesion at point B is what? Optic chiasma. And you know what is crossing? What is crossing? Bitemporal. So that will cause bitemporal hemianopia. Bitemporal hemianopia. Why? Because crossing over is happening at the level of optic chiasma. And if the level of lesion is C, it causes homonymous hemianopia. If lesion is at point C, it causes homonymous hemianopia. And if lesion at point D, it causes homonymous hemianopia with macular sparing. I cannot go in very much detail because this session is purpose is to revise whole physiology in the form of image. That is why I have to be fast, but the purpose here is to revise. If you want to see whole video, you can go to the app and see whole video. Here purpose is only to revise. So point A, whole eye. Point B, bitemporal hemianopia. Point C is homonymous hemianopia, and point D lesion is, doctors, homonymous hemianopia with macular sparing. Absolutely correct, Dr. Shiv Chaudhary. You are absolutely correct. Thank you. Now, this is a wonderful diagram. Cochlea, everyone know it is for hearing. We know the primary function of your ear is hearing or balance. It is balance. It is balance. See, we have semicircular canal. We have 3 semicircular canal, and each are at perpendicular to each other, and they are for angular, or you can say rotational acceleration. We have 3 semicircular canal. It has crista ampullaris, in which we have cupula. We have discussed in very much detail this chapter. This is very, very important. A lot of questions has been asked. 3 semicircular canal, each are at the 90-degree, and they are for angular acceleration, doctors. And they have crista ampullaris, they have cupula, C, remember, circular, C, crista, C, cupula. All are C. Remember like that. Very good, Dr. Shiv Chaudhary. Posterior, lateral, and superior. Namaste, Asmit. Namaste. How are you? Okay. Now, we have utricle and saccule. Both are called as otolith organ. Both are called as otolith organ. Okay, because they have otolith. I will show you. Very good, Shiv. You know the cupula covers the crista. Wonderful. Your depth is very nice. Okay, so otolith organ are utricle and sacculus, and otolith organ are for linear acceleration. Linear acceleration. So एक है linear acceleration, एक है rotational. Suppose you are driving a car. You are driving a car. So you are driving a car. So it is horizontal acceleration. So remember, you are driving a car. So utricle is for horizontal acceleration. Yes, Dr. Bhavya, you are correct. Horizontal acceleration. In the linear, there can be horizontal and there can be vertical. So if you are driving a car, you are moving against the gravity. That is sensed by utricle. That is sensed by utricle. But if you are in a lift, and going up like that, Okay, what will happen? Who will work? Saccule. Saccule is for vertical acceleration. So point to remember, number one, semicircular canal are for angular acceleration, pista impularis and cupula. Otolith organ are two, utricle and saccule. Utricle is for horizontal. If you are driving a car, you go like this. If you are in the lift, it is something like this. Okay, now these are otolith organ, hair cells and the nerve, and they are otolith, calcium carbonate. Okay, you discuss in very much detail. Now, for accommodation reflex, we have discussed the visual reflex, we have discussed the light reflex. Now, accommodation reflex. For accommodation reflex, you have ciliary body. If you are looking at the close, if you are reading a book, okay, ciliary body will contract. If you are reading a book, ciliary body will contract and zonules will relax. Please understand this. If you are looking far, ciliary body will relax. If you are looking far, they will relax and these zonules will contract. Don't confuse with the light reflex and accommodation reflex. That time I have discussed about the light reflex. And what is Urgell-Robertson pupil? Urgell-Robertson pupil. Tell me, doctors. Very good. Accommodation reflex is present, and light reflex is absent. So if accommodation reflex is present, but light reflex is absent, it is called as Urgell-Robertson pupil. And there are so many examples. One can be neurosyphilis. The thing is that the pathway is damaged. Edinger-Westphal nucleus, whatever the pathway we discussed, that is damaged. Okay. And this is the area from where optic nerve and the veins and retina are coming out. It is called as blind spot. It is called as blind spot. This is fovea centralis, I have discussed. The yellow one is retina. Remember RCS. R is retina. It is a neural layer. Vascular layer is choroid, and the outer tunic is sclera. So this is a tunic. How many tunics are there? Outer is sclera, middle is choroid, inner is retina. This is your vitreous chamber. This is your aqueous chamber, and this we have discussed already. And this is your vitreous fluid, jelly-like. Now, if you talk about the cutaneous receptor, touch receptor, we know there are 4. These are superficial. These are superficial. Namaste, Jasmeet. Namaste. So, Meisner's and Merkel, they are superficial. Pacinian and Ruffini, they are, in comparison to that, they are in the depth. Meisner's are for lateral descent, lateral motion. Pranam Arjun, how are you? You are there. So if you are sensing, suppose there is a cloth. If I am sensing this cloth, this is your cotton or polyester or whatever. If you are sensing during the lateral motion, which receptor will be involved? What is the answer? Meisner's corpuscle. It is the Meisner's corpuscles. So if you do the lateral motion, okay, who will sense? Meisner's. And Merkel, if I put finger on this tip, so if you are sensing the edge, it is the Merkel disc. Merkel disc. तो Merkel मतलब कील, हिंदी में बोलते हैं ना कील. अगर एक हाथ पे कील चुभ गई तो कौन सा रिसेप्टर काम आएगा? Meisner's या Merkel? Answer will be Merkel. And Meisner's are maximum at your lips and fingertips. If you want to feel something with your, yes, maker ki tarah. Yes, if you want to feel something with your finger or your lips, you have to do lateral motion. You know that. So lateral motion is made if you want to feel with your fingertips or your lips. It is your Meisner's corpuscles. And if you want to put your hand on the tip, it is the Merkel. Now, Pacinian, please remember this diagram. It is the shape of onion. Shape of onion. Sense vibration. Shape of onion and sense vibration. So who is sensing vibration? Yes, Pacinian. Pacinian, onion, vibration. Remember like that. Measner's lateral motion. Merkel, edge, tip. And Ruffini is for constant pressure and stretch. If someone is stretching your hand like this, putting some constant pressure, who is involved, doctors? Tell me. It is Ruffini ending. It is Ruffini ending. Okay, so these are the four receptor. Now, so if there is upper pontine damage or upper midbrain damage, what will happen? So doctors, you know, this is your cortex, midbrain, pons and medulla. Pons and medulla. So if lesion, this is your midbrain, doctors. This is your pons. This is your medulla. Okay. Now, if lesion is upper pontine, tell me, doctors, if lesion is upper pontine, actually in the midbrain, you have ruborospinal tract. You have ruborospinal tract. If lesion is upper pons, the cortex is gone, midbrain is gone, and this is called as decerebrate rigidity. Decerebrate. You are correct, Dr. Shiv. Very good. Remember this, very good. Decerebrate rigidity. So because ruborospinal tract is intact, so hands are like this. Hands are like this. Hands are lying at the side of the body. It is called as decerebrate rigidity. But if lesion is at the level of upper midbrain, like this, if lesion is at the level of upper midbrain, only cortex is gone, and it is called as decortication. This is called as decortication or decorticate rigidity. तो अगर ऊपर का माला गया तो हाथ ऊपर, अगर नीचे का भी माला गया तो हाथ नीचे, सिर्फ कॉर्टेक्स गया. अगर लेजन सिर्फ कॉर्टेक्स में, if lesion is at the level of only cortex, okay, hands are like this. Why? Flexion of hand is due to which tract? It is because of the ruborospinal tract. Is this clear? I've discussed this again in at least 1 or 2 hours. This is a detailed topic just for revision purpose. अगर ऊपर का माला गया तो हाथ ऊपर, अगर नीचे का गया तो हाथ नीचे. Now this is your antigen presenting membrane and this is your T cell. Once in INICET they ask, okay, the antigen fragment is between which subunit? So please remember, antigen presentation is done by mainly antigen presenting cell. It can be dendritic cell, it can be macrophage, whatever. But remember, they are alpha 1, alpha 2, alpha 3, and beta 2 M unit. And the antigen is lying between alpha 1 and alpha 2. Alpha 1 and alpha 2. Is this clear? And T cell receptor has a constant region. और एक बार क्वेश्चन आया था, which bond is there? Answer is disulfide bond. It is a disulfide bond. Is this clear? So please remember this image. If you remember the images of Guyton and Ganong, you remember a lot of things. Okay. Now, this is your two pathway. One pathway is your, remember, this hearing pathway. The mnemonic is E. coli MA. The mnemonic for hearing pathway is अल्फाज मेमन. सर प्लीज शायरी तुम कुछ अल्फाज लिखो कमेंट में, शायरी वाले. यू फ्रॉम जासू. ओके, अभी देखते हैं. तो ई इज व्हाट इज ई? ई इज 8th क्रेनियल नर्व. बहुत आसान है. ई कोलाई MA. व्हाट इज ई? Yes, E. coli MA. Very good. Everyone knows this mnemonic. Wonderful. What is C? Tell me. What is C? Doctors? Wasim? Arjun? Arjun bhai, क्या हाल है? C is what? Cochlear nucleus. You can see here. Dorsal and ventral cochlear nucleus. What is C? Cochlear nucleus. Dorsal and ventral. Dorsal and ventral cochlear nucleus. What is O? O is superior olivary nucleus. Okay. What is L? Anyone can tell me L? What is L in E. coli MA? This is from cochlea. This is your wonderful lateral lemniscus. Medial lemniscus कहाँ पढ़ा था हमने? Dorsal pathway में. Dorsal pathway में. It is a lateral lemniscus. What is the E? Sorry, I. I is inferior colliculus. सुपीरियर कॉलिकुलस आंखों के लिए है, इंफीरियर कान के लिए. आंख ऊपर होती है, कान नीचे होता है. सो आईज आर सुपीरियर, तो सुपीरियर कॉलिकुलस, एंड ईयर इज इंफीरियर. कान नीचे होते हैं, आंख ऊपर होती है. सो आई इज सुपीरियर कॉलिकुलस एंड योर ईयर्स आर इंफीरियर कॉलिकुलस. M is medial geniculate body. विजन में कौन सा होता है? लैटरल. L फॉर लाइट, M फॉर म्यूजिक. तो हियरिंग के लिए म्यूजिक चाहिए, तो मीडियल जेनिकुलर बॉडी. एंड A इज ऑडिटरी कॉर्टेक्स. A इज ऑडिटरी कॉर्टेक्स. Am I clear? So nothing to forget here. It's very simple. E. coli MA. But please don't forget, it is lateral lemniscus, doctor. Okay. And M is medial geniculate body. Don't say L for lateral geniculate body. Remember, L means light. So in the visual pathway, we have discussed lateral geniculate body, and here we have discussed medial geniculate body. And this is the secondary function of ear. Primary function is balance. बढ़िया. तो primary function is balance. ठीक है. तो from utricle, sacral, semicircular canal, all the impulse will go to vestibular nucleus, and from vestibular nucleus it goes to third cranial nerve. You know all that. Third cranial nerve, fourth cranial nerve, and sixth cranial nerve. Third, fourth, and sixth. Wonderful. Wonderful. You all know that. Third, fourth, and sixth. So that suppose I am focusing on this pencil and my head is going like that, my eyes are moving like this. So all nowadays you all have Apple phone and Samsung Galaxy phone. They all have stability feature. But all those cameras are not working properly. Only this camera is working properly. Because even if you're running and your eyes are focused somewhere else dangerously, okay, your image is not blurred. अगर हम दौड़ भी रहे हैं और हमारी निगाह कहीं पर फोकस है, तब भी हमारी इमेज ब्लर्ड नहीं आती. क्यों? बिकॉज ऑफ दिस VOR, vestibulo-ocular reflex. Vestibulo-ocular reflex, it is the basis of nystagmus, the slow component and the fast component of nystagmus. Okay, sometime I will discuss in more detail, but please remember this pathway. Now comes your retina. This layer is pigment epithelial layer. Purpose is to absorb light. Purpose is to absorb light so that your image should not be blurred. These are your rods and cones. These are your rods and cones, and all these nucleus are outer, so they are called as outer nuclear layer. So many MCQ in your examination about the outer nuclear layer. Okay. Then these rod and cones are forming plexiform on the bipolar cell. So these are called as, this is called as outer plexiform layer. This is called as outer plexiform layer. And after that, you have all other nucleus. It is of bipolar cell. It is of amacrine cell. It is of what else? Horizontal cell. All these form inner nuclear layer. Inner nuclear layer. Sometimes they ask you in the exam, outer nuclear layer is formed by what? The answer is rod and cone. Outer plexiform between rod and cone and bipolar cell. Inner nuclear layer is formed by all other cells. And doctors, these are again your inner flexiform layer, and these ganglion cell form optic nerve. They are the axon of optic nerve. And please remember, out of this 7 cell in the retina, which is the only cell in the retina that cause action potential, doctors, this is action potential is caused by ganglion cell. The only cell in the retina that can cause action potential, it is your ganglion cell. And then we have Muller cell. Muller cell delineate, so it is called as inner limiting layer. Inner limiting layer. Muller cell delineate, it is called as inner limiting layer. Jamal bhai, love you too. Okay, so inner limiting layer is formed by Muller cell. So Muller cell is the only cell which has no role in visual processing. Muller cell is the only cell which has no role whatsoever in visual processing, and outer limiting layer is between the cell body and the nucleus of photoreceptor. It is the outer limiting layer. Bundles of questions are there with this image. Okay. So this is your, now endolymph have lot of potassium, and perilymph have a lot of sodium. We know that. Endolymph, so after the function is over, it is again taken by the pump, and this potassium get back into the scala media. So scala media has endolymph, vestibuli and tympani have perilymph, doctors. Okay, and they have more of the sodium, and they are found by stria vascularis. You know all this. I know you all know. You all are very nice doctors. I'm just revising so that you should not make any mistake in the exam. Wonderful. I'm really proud of all of you, because when I was in my MBBS days, my physiology was very weak. But when I go to teach you all, and I can say the level of improvement which is coming through the generation and generation, the seriousness is increasing day by day. Students are becoming more and more bright. That is why competition is increasing. This is the reason. इंटर्नशिप में बहुत ज्यादा ड्यूटी करवा रहे हैं, ऐसी जगह से इंटर्नशिप क्यों किया? यस रवि शर्मा, थैंक यू. वो भी जरूरी है. देखो, जब जब हम इंटर्नशिप में ड्यूटी करते हैं ना, तो टाइम की इंपॉर्टेंस समझ में आती है. भागे भागे घर पे आते हैं, फिर पढ़ते हैं बैठ करके रात में 2 बजे तक, 3 बजे तक, 4 बजे तक, फिर ड्यूटी करने जाते हैं. तो दिस इज द इम्पोर्टेंस ऑफ टाइम. दिन भर खाली बैठे रहोगे तो पढ़ने में भी मन नहीं लगता. थैंक यू डॉक्टर शिव. दिन भर बैठने से भी नहीं होता है. इतना बिजी रहो कि मरने की भी फुर्सत ना रहे. जैसे ही माइंड को खाली छोड़ोगे, एंग्जाइटी, डिप्रेशन, ऑल दोज थिंग्स, इसको पूरी टाइम लगाया रहो. एनीवे, so this is called as which position, doctors? It is called as cogged position. Cogged position. So when this is your light chain, this is your heavy chain, and they are emerging like this, it is called as cogged position. Okay, so actin और myosin दोनों पास पास हैं, फिर भी contraction नहीं हो रहा, क्यों? This is your all India PG question, that even actin and myosin are close together, but why there is not contraction? What is the reason? Reason is tropomyosin. Very, very important point. Tropomyosin is a relaxing protein. It covers myosin binding site on actin. ये जो मोती की माला है, ये माला है एक्टिन की. ये माला है एक्टिन की. इस पे जो ये डीएनए के जैसा आया है, ये ट्रोपोमायोसिन है. ओके, तो ट्रोपोमायोसिन इज लाइक अ डीएनए स्ट्रक्चर, हेलिकल स्ट्रक्चर, एंड इट कवर्स myosin binding site on the actin filament. So there is no contraction. And this position, doctors, it is called as cogged position. Please don't forget this. It is called as cogged position. So what happened when calcium come? What happened when calcium come, doctors? Tell me. Very good, excellent. Troponin C combined with the calcium, very good, excellent. And cause, when calcium combined with troponin C, it cause conformational change to uncover myosin binding site on actin. Wonderful. Perfect answer. Perfect answer. So what happened when calcium come, doctors? Tell me. When calcium come, it combined with troponin C to cause conformational change to uncover myosin binding site on the actin filament. And actin myosin will combine together to cause contraction. Isn't it? Very good. This much is clear. Now, this longitudinal force is called as power stroke. It is called as power stroke. It is called as power stroke. Both in the both middle direction. So when it causes contraction, there will be power stroke. And remember, this is the AIMS question. This is question from INICET. What happens when ATP binds with the myosin filament? Contraction or dissociation? Believe me, doctors, when ATP bind with the myosin, it causes dissociation of head of myosin. ऐसा नहीं कि ATP आएगा contraction करेगा, नहीं. When ATP combines with the myosin head, it causes dissociation. This is your actin, this is your myosin. It causes dissociation, doctors. Yes, you are absolutely correct. Okay, and then after that, ATP will be broken down into inorganic phosphate and ADP, and it will again come in cogged position. Cogged position. So one ATP is required for contraction as well as relaxation. One ATP. So you can say half for contraction, half for relaxation. Now, doctors, see this. Normally, we know this is the normal. When potassium level is normal, suppose that 4 to 5.5 milliequivalent, the normal range per liter. You know, ECG is normal. But when potassium level increase, yes, Dr. Sachin, tell me. Dr. Sachin, बताइए, अगर potassium level 7 milliequivalent हो जाए per liter, तो what is the first change of ECG? पहला change क्या मिलेगा? There are plenty of changes, I tell you. मगर mild hyperkalemia, moderate to severe hyperkalemia, nowadays they are asking all the questions. तो अगर पोटेशियम लेवल 7 मिली इक्विवेलेंट पर लीटर मिल जाए तो पहला चेंज होगा, यस, टॉल. वेरी गुड डॉक्टर प्रत्युषा कुडेला, वेरी गुड. द फर्स्ट चेंज इज टॉल टी वेव. टॉल टी वेव, वेरी गुड. वसीम अकरम, वेरी गुड. टॉल टी वेव, वंडरफुल. बट अगर पोटेशियम हो जाए 8.5 मिली इक्विवेलेंट पर लीटर, okay, of course tall T wave is characteristic, you know that. But if there is severe hyperkalemia, it is the process of accommodation when your heart will stop. I have discussed in detail in the video lectures. But just tell me, there are two other features. P wave will be absent because there is no atrial depolarization. We only remember tall T wave, but nowadays they are asking all the features. So not only the tall T wave, but the absent P wave, and QRS will be wide. You can see wide QRS. QRS will be wide. And doctors, in hypokalemia, suppose, let me say one value 3.5 or 4. किसने ब्लॉक कर दी सचिन को भाई? Okay, anyway. ST depression. ST depression. तो जो पहला फीचर आता है, of course U wave is there, you are correct, U wave is there, but the first feature is ST depression And when potassium goes below that 2.5, then you get U wave. U wave. Clear? Yes, absolutely correct. Your answers are absolutely correct, doctors. Now, Broca's area is for word formation. It is for word formation. Okay. Wernicke's area is for comprehension. Understanding. अभी मैं हिंदी में बोल रहा हूँ, समझ में आ रहा है, अभी इंग्लिश में समझ में आ रहा है, अभी मैं अरबी में, अभी फारसी में बोलने लगूँ, सपोज मैं फारसी में बोल रहा हूँ, फारसी में बोलता हूँ, चलो एक शेर बोलता हूँ फारसी में, समझ में नहीं आएगा। मैं इशरत न थी ताले में अपने सा किया वरना, मैं इशरत न थी ताले में अपने सा किया वरना, फलक मीना लिए फिरता तो मैं जिंदा लिए फिरता, परंगे ना लाए मैं जिंदा में हूं लेकिन मेरा दीवानापन मुझे जिंदा से है बाहर लिए फिरता। कुछ समझ में नहीं आया, क्यों? ये फारसी है। You don't understand Farsi language. Why? Because Wernicke's area is for understanding. You are not trained for Farsi language. So how can you understand the Farsi language? So comprehension is by Wernicke's area, and speaking, I can speak because of the Broca's area. So if there is a Broca's aphasia, if there is Broca's aphasia, doctors, okay, it is called as non-fluent aphasia. Understanding is there. Understanding is there, but fluency is gone. Understanding is there, but fluency is gone. It is called as Broca's aphasia. And if Wernicke's aphasia is there, fluency is there, but understanding is gone, it is called as fluent aphasia. It is called as fluent aphasia. Okay. And if the fiber which connect Broca's with the Wernicke is called as arcuate fasciculus. And doctors, if the lesion is of the arcuate fasciculus, it is called as conduction aphasia. इसको बोलते हैं conduction aphasia. Word formation is there, understanding is there, but what is lost? क्या चला जाएगा? क्या जाएगा? Repetition is gone. Only one thing is gone. Repetition is gone. If I say just repeat the same sentence, whatever I told you, you cannot repeat that. It is called as conduction aphasia, doctors. Okay. Now one more aphasia. If the lesion is of angular gyrus, it is called as anomic aphasia. Visual blindness, word blindness. Because whatever you are seeing my video. It is going to your retina, then lateral geniculate body, then your cortex. And for understanding, it is going to Wernicke's area. But before Wernicke's area, you have angular gyrus. Okay. So this is the reason that even if I say something, you can understand. But if I write something, it is going to your retina, then your cortex, then your Wernicke's area. But there is a lesion of angular gyrus. It cannot go to the angular gyrus. So you cannot understand the written language. It is called as anomic aphasia, doctor. And problem is with the written language. Problem is with the written language. Word blindness. मैं बोलूंगा सब समझ में आएगा, मगर मैं लिख के दूंगा कुछ समझ में नहीं आएगा. मैं कहूंगा ये क्या है. You cannot say this is a watch. Why? Because it is going to the cortex. But for understanding this is a watch, you need Wernicke's area. But angular gyrus is gone. And this is the most common question asked nowadays in your examination. Okay. Now you know this is a finger. Sometimes they ask you finger nose test. You all this is about the cerebellar disorder. Cerebellar disorder. Normally, if I say if eyes are closed, you can do like that. But if cerebellum is not working properly, you will do like this. Which lesion is there? Cerebellar disorder. Now this is your pyramidal tract, doctors, coming from P-central gyrus. Okay, internal capsule. 80% fiber decussate here in the medulla. It is called as lateral. It is called as lateral corticospinal tract, and this is for skilled activity, skilled voluntarily activity. Suppose I am writing, so this writing, or you are doing some surgery, okay, this is due to lateral pyramidal tract, because 20% ventral is only for gross movement. It is for gross movement, or you can say for posture. Okay. So please remember, all pyramidal tract are not for the skilled activity, only those that cross lateral corticospinal tract. Now, doctors, tell me, if you see the ocular movement in the REM sleep, only in the REM sleep you can see ocular movement in NREM stage 1, in NREM stage 2. Yes, so एक बार सारे lobes के function बता देना. Okay. See, cerebellum has 3 parts. One is called as neocerebellum, other is called as paleocerebellum, third is called as archicerebellum. Neocerebellum, doctor, it is for coordination of movement. Coordination of the movement. Paleo, number 1 function is to maintain muscle tone. Number 2 function is diadokinesia. Diadokinesia, I mean ability to perform rapid alternate movement. Archicerebellum or vestibular cerebral tract, it is for balance. It is for balance and posture. Okay. So when you are having a REM sleep, you have extraocular movement in all other NREM sleep. NREM sleep has stage 1, stage 2, stage 3, stage 4, doctors. So no ocular movement. But muscle tone is decreased in only REM. आंखें तो चल रही हैं, but body is paralyzed. I told you, REM sleep नहीं है, धोखा है. REM sleep is not a sleep, it is a धोखा जो ब्रेन ने दिया है बॉडी को, जो ब्रेन ने दिया है बॉडी को पैरालाइज करके खुद पिकनिक पे चला गया है. वापस आता है, देखता है, चेक करता है बॉडी है, फिर चला जाता है. तो REM sleep is not a sleep, it is a धोखा. Your body is paralyzed. I must not use the word paralyzed. Muscle tones are decreased. Muscle tones are decreased. Okay. And paradoxically, your brain is active. It has alpha wave, beta wave in REM sleep. Okay. So anyway, now coming to EEG. EEG awake. When you are awake, you have alpha wave, you have beta wave. In stage 1, you can see here, you have alpha wave and you have theta wave. I will give you mnemonic also just right now. And in stage 2, you have biphasic K complex. You have biphasic K complex, and you have spindle like this called as sleep spindle. They are called as sleep spindle. Stage 3 and stage 4, doctors, you know, delta wave. Delta wave. And REM sleep, you know, REM sleep have alpha wave and beta wave, like now, what we have. The mnemonic is gamma. How to remember the mnemonic? Gamma, bat, dance. Gamma more than beta, more than alpha, more than theta, more than delta. गामा कब होती है? गामा कब होती है? जब तुम बहुत फोकस होते हो. When you are very focused. Yes, you are correct. Only when you are very focused. Suppose in the class there are, suppose 100 people are there, 50 of you are very focused. Okay, you will have gamma wave. So your frequency will be 30 to 80 hertz. Very high frequency because you are very focused. But if you are thinking, if you are ठीक है, focus भी हो, मुझे भी सुन रहे हो और साथ में किसी और को भी सुन रहे हो, साथ में WhatsApp मैसेज भी चल रहा है. You know, आजकल you all are doing multiple things at a time. It is not a good thing. So you have beta wave. Beta, अगर तुम beta लिखोगे 13 लिख जाएगा. 13 to 30 hertz. 13 to 30 hertz. Alpha 8 to 13. Theta 4 to 7. Delta less than 4. तो जब तुम सुन रहे हो लेक्चर बहुत ही ध्यान से, वेरी फोकस, frequency is 30 to 80, less focus, beta. Now your eyes are closed. Okay, now I will close my eyes and I will listen to Naveen sir what he is saying with full concentration. But you know, when your eyes are closed, you are relaxed, you have alpha waves, and you forget about the class and you go in theta NREM stage 1. नवीन सर बोल रहे हैं, हम हल्की हल्की नींद में, गहरी गहरी नींद में सो रहे हैं, और कब गहरी नींद में चले गए पता नहीं, स्टेज 3 एंड स्टेज 4. सो हमने स्टार्ट किया था क्लास जब यू हैव डेल्टा वेव, आफ्टर सम टाइम थोड़ा सा जोश कम हुआ, बीटा वेव, फिर आंखें बंद हुई और सुन रहे हैं, आपको ऐसा नहीं कि नहीं सुन रहे हैं. देन विच वेव? अल्फा वेव. और सुनते सुनते कब मीठी मीठी नींद, हल्की हल्की नींद, दैट इज थीटा वेव. एंड थीटा वेव कब गहरी नींद में आ जाए? डेल्टा वेव. डेल्टा वेव मीन्स डीप स्लीप. सो गामा बैट डांस, गामा बैट डांस. Okay. Now this is about the lesion of the tract, doctors. If lesion is, I will not go in very much detail, just let me tell you, if lesion is below the medulla, lesion is below medulla, respiration will stop. Respiration will stop. If lesion is between medulla and pons, it will cause between medulla and pons. See, medulla and pons. Medulla is the generator of respiration. Pons is the maintainer. Medulla is Brahma, who generate the respiration. Pons is like Vishnu, who maintain the respiration. You can say like that. Medulla is the pacemaker, wherever respiration is generated. And pons is like, maintain the fine tuning of respiration. So if lesion between medulla and pons, Brahma is there, Vishnu is gone. So respiration become irregular. Respiration become irregular. Medulla is generator, pons is the maintainer of the respiration, doctors. So if lesion below the medulla, okay, respiration stop. If lesion between medulla and pons, irregular respiration, doctor. And if mid-pontine lesion, doctors, mid-pontine lesion, now vagus intact, it will be deep and slow. And if vagus also cut, it causes apneustic breathing. Apneustic breathing, I have detailed discussion of this chapter in my video, and also in YouTube. If you can see Dr. Tutorials app, you can see the video. So just remember, below the medulla, respiration gone. Medulla and pons, respiration irregular. Mid-pontine, vagus intact, deep and slow. Vagus cut, apneustic breathing. Yes, medulla has pre-Borzinger complex. You are absolutely correct, Dr. Shiv. Okay, I am exceeding my limit. I think I should take part 2. Time is already gone. Okay, let me discuss one more thing. Unipolar cell is the cell there is no differentiation between dendrite and axon. It is called as unipolar cell. Okay. And bipolar cell is the cell which has one dendrite, one axon. An example is bipolar cell of the retina, of the olfactory nerve. Pseudo-unipolar is actually bipolar, look like unipolar. And please remember the example, dorsal root ganglion cell. Dorsal root ganglion cell. And 3 types of multipolar. Every image has been asked in your exam. Recent question was this one. They have given you this image and asked you which cell is this, doctor? It is Purkinje cell of cerebellum. Recent MCQ in NEET PG as well as INICET examination. Then this is the pyramidal cell of hippocampus, and this is the motor neuron. These are high yield topics. Please remember. Now, I told you your thalamus is like an antenna, doctors. Lateral geniculate body has how many layers? Remember, 6 layers are there. In the thalamus, the antenna is the thalamus. And for the vision, it is lateral geniculate body. 6 layers are there. 2 are called as magnocellular. It is for movement of eyeball. It is for movement of eyeball. And parvocellular are for color vision. In one of the NEET PG examination, I don't remember the year, 3 questions were only from lateral geniculate body. 3 questions in one exam. If you know, you know. If you don't know, rank is very, very, very poor. Why? Because 3 questions is very important. How many layers are there? 6 layer. 2 layer magno, 4 layer parvo. Magno is for movement of eyeball, parvo is for color vision. Okay. Now, tight junction is zonular adherence. You know that. This is zonular adherence, desmosome. The only difference is that adherence bind with actin. Desmosome bind with intermediate filament. And gap junctions are formed of protein called as connexon. One connection is made up of 6 subunits called as connexin. And mutation of connection causes Charcot-Marie tooth disease. Charcot-Marie tooth disease. Okay, now very important. I cannot skip this. It will take only just 5 or 10 minutes. I will cover everything. Just give me only 10 minutes. I will exceed only 5 or 10 minutes. Okay. Although I promised I have to finish in 1 hour, but just give me 10 minutes. This is very important topic. I cannot skip that. So you have A band, you have I band, you have H band, doctors. See, this is your actin. These are your actin. Middle one is your myosin. Middle one is your myosin. This is your Z line. This is your Z line. Okay. And this dark, if you see the dark, it form what? Which band? A band. Remember by dark. Remember dark. Dark has A. So the dark segment formed by the overlapping of actin and myosin is by A band, and this is your I band. This is your I band, and the difference between this is called as H zone. This is called as H zone. Why it is called as H zone? It is a gap. It is a gap, so that when contraction happen, H zone will decrease. H zone will decrease. So when contraction happen, you can see this is called as H zone. This is called as H zone. So in the exam, they ask you, very good, Pratyusha Kola, you are very updated with the recent MCQ. Vibrio cholera, yes, it is zonal occurrence. You are absolutely correct. This is the latest INICET question. Very good. So during contraction, what happened, doctors? 2 Z line come closer. You can see 2 Z line come closer. I band and H zone decreases and A band remain constant. These are the questions. What happened during contraction, doctor? 2 Z line come closer. 2 Z line come closer. I and H will decrease. A band remain constant. Okay. So this is it for today's lecture. Thank you for your consistency throughout the class. You all were participating in the lectures. So thanks a lot. And any query you can ask me, or if you want me to take other class also, live class for some topic, you are free to message me. You can message me on my Insta ID or Facebook, whatever doubt you have after seeing the videos and everything, you can ask me. So a big thank you and all the best for your exam. Yes, अल्फाज शायरी शायरी ऐसे तो याद नहीं है। एक शायरी अच्छा कभी यूं भी आ मेरी आंख में, कभी यूं भी आ मेरी आंख में कि मेरी नजर को भी खबर ना हो, और मुझे एक रात नवाज दे मगर उसके बाद कोई सहर ना हो, सुना है तू बड़ा रहीम ओ करीम है, तो मुझे ये सिफत भी अता करे, तुझे भूलने की दुआ करूं पर मेरी दुआ में असर ना हो। ओके, फिर अगले क्लास के लिए और भी शायरी। आज के लिए इतना काफी है, आई थिंक। थैंक्स अलॉट सभी को, बड़ा बहुत सारा प्यार देने के लिए। आई एम ओनली बिकॉज ऑफ यू पीपल। मैं जो कुछ भी हूँ सब तुम लोगों की वजह से हूँ। थैंक्स अलॉट। यस प्रत्युषक, आई विल इन्फॉर्म यू, आई विल इन्फॉर्म यू वेरी सून। ओके, थैंक यू। गुड नाइट एवरीवन, गुड नाइट। दिल से पढ़ो, जल्दी मिलते हैं। Sir, one question. Any more DNA exam will happen? Yes, Vivan Dubey. Any more DNA? I cannot understand what you. Can you write again? Okay, you can message me in my personal box. I will inform you. So all the very best. मिलते हैं बहुत जल्द. Bye bye. Take care. Love you all. Bye.